Hello, this is Dr. Susan McElroy, and I'm going to be providing an update regarding what's new in the medical treatment of psychiatric disorders. I'm from Lindner Center of Hope and the University of Cincinnati, and I want to thank you very much for inviting me to present to you. Here's a slide with my disclosures. I do consult to a number of drug companies. Also, many of the treatments I'm going to discuss are experimental and not yet FDA approved. And I will try to point out when something is FDA approved for a certain mental disorder versus when it's not. So what I hope to do in the next 45 minutes or so is to describe some of the new and developing medical treatments for schizophrenia, depression and bipolar disorder, post-traumatic stress disorder, eating disorders, obsessive-compulsive disorder, and then talk a little bit about one of my prime areas of research, and that's treating people who have both a mental disorder and obesity. Before I get to the specific disorders and the specific treatments, I do want to stress one thing that we have really learned over the past 10, 20 years, and that is the vast majority of mental disorders are related to one another. They're almost all mental disorders are what we call complex genetic disorders, where many genes contribute small effects to getting the illness, and it's clear that different mental disorders share genetic liability, and they also co-occur. So they occur with one another. So if an individual has one mental disorder, they more than likely have others. Therefore, an individual who comes in for the treatment of a mental disorder must be evaluated not just for the index mental disorder, but for virtually all other mental disorders, because we have to determine a person's psychiatric profile. In other words, their primary disorder and all the co-occurring ones, to determine their best medication treatment plan. You're going to see how this is relevant in that many of the new treatments for the disorders are similar to one another. So treatments for schizophrenia are similar to treatments for bipolar disorder, which are similar to treatments for major depressive disorder. And I'd also just like to say that this contrasts with neurological disorders, which are independent of one another. So Parkinson's is independent from stroke, independent from meningitis, with the interesting exception of migraine headaches. And migraines, we know, have very high co-occurrence with mental disorders. So if somebody comes in with a mental disorder, we really need to evaluate for migraine. Conversely, if somebody has migraine, they really need to be evaluated for mental disorders. Here's just one slide that depicts this degree of comorbidity. This is an epidemiologic sample. In other words, this is a sample of people from the community. They weren't seeking treatment. They're from the community. They all had bipolar disorder. And what was done is the other disorders that these individuals had was assessed. And it's just striking, so that the vast majority had an anxiety disorder, at least one. and the majority had a substance use disorder or alcohol dependence. So, and this is really true for almost all mental disorders, so that when somebody comes in with a mental disorder, to really optimize their treatment, you need to assess for all other mental disorders. Okay, so let me talk a little bit about schizophrenia. There is a novel treatment that's just been approved for the treatment of schizophrenia called lumateperone or Caplyta. This drug is a novel second-generation antipsychotic. Its efficacy has been shown to be comparable to risperidone. So the efficacy profile may not really be a huge advance. What is an advance for this compound is the drug's side effect profile. It has minimal metabolic and extrapyramidal side effects. And this is a big deal, and I'll come back to this theme again and again. So this drug, it looks like it does not cause weight gain, and it doesn't cause abnormal movements. And we'll come back to this drug. A drug that, lumateperone is in fact available. It is approved by the FDA for schizophrenia. A drug that's currently undergoing research is a compound called SEP 363856. This compound is exciting because it does not block dopamine receptors like all the other compounds that are efficacious in schizophrenia do. So there's a positive phase 2 study. If the compound is being evaluated in phase 3 studies, if this turns out to be truly safe and efficacious for schizophrenia, this will be very exciting for two reasons. Number one, it targets a different receptor within the brain. It doesn't target dopamine D2 receptors, rather it targets something called trace amine associated receptor 1. So we really need new medications with novel mechanisms of action. Another exciting potential feature of this compound is that it might be efficacious in the negative symptoms of schizophrenia. All of the drugs we have available for schizophrenia are pretty effective for reducing the so-called positive symptoms of the illness, things like delusions and hallucinations, the active psychotic symptoms. What our current drugs are not terribly effective at is treating the negative symptoms of schizophrenia, the apathy, the withdrawal, the cognitive dulling. And so if this is, there's a ways to go, but if this drug turns out to be helpful in schizophrenia, it'll be not only a different mechanism of action, but possibly be helpful in the negative symptoms of the illness, which we know are associated with a lot of the morbidity of schizophrenia. Okay, so now let me talk a little bit about new treatments for bipolar disorder. And here are three somewhat recently approved, there's 2 approved treatments, and one has just been shown to be effective in bipolar depression, is not yet approved for bipolar disorder. So these drugs are lurasidone or Latuda, cariprazine or Vraylar, and lumateperone, which I just mentioned was approved for schizophrenia. So these are all second-generation antipsychotics. So what's interesting is that these are all drugs that have been approved for schizophrenia. but they work in bipolar disorder. Specifically, lorazepam is approved for bipolar depression. Cariprazine is approved for bipolar depression and mania. And then lumateperone, the drug I just talked about, now has 2 positive studies in bipolar depression. So what's exciting about this is that it looks like this class of drugs, which is very helpful for schizophrenia, is also helpful for people with bipolar disorder. And then with respect to the last compound, the newest compound, lumateperone, which isn't yet approved for bipolar depression, we again saw this very benign side effect profile. So it worked in bipolar depression with no weight gain and no movement abnormalities. What I like to digress a little bit and remind people that our best treatment still, despite years and years and years of research, for people with schizophrenia and bipolar disorder that doesn't respond to our standard medications is still clozapine. This is an old drug. It's indicated for schizophrenia. It's not indicated for bipolar disorder, but bipolar experts use it all the time when we have patients who are treatment resistant. It can work when nothing else works. It has been shown to reduce the risk of recurrent suicidal behavior in schizophrenia, and it may also reduce tardive dyskinesia. Unfortunately, it's a very difficult drug to tolerate and use. It's associated with a number of serious side effects. The one we worry most about is agranulocytosis. It can suppress your white blood cell count, and that's why people who go on this drug have to have their blood monitored to make sure that their blood counts are all fine. Sorry. It also can cause heart problems, very severe constipation that actually can be lethal in rare cases. It can cause seizures. And then one of the most problematic side effects is the weight gain. And so clozapine, I've used this drug for many years. It still will work when nothing else works, but it does have an important side effect burden. And because of that, probably people who should be getting the drug aren't getting it. So one of the most important side effects is the weight gain. And I'll be getting back to that. Okay, what about new treatments for major depression? Well, I'd like to highlight 3 areas. Number 1, again, we come back to the second generation antipsychotics. These drugs, a number of these drugs, have been shown to enhance or augment the antidepressant response to a traditional antidepressant. Again, here, very interesting finding. Here's a compound. These are compounds that are helpful for schizophrenia. They're helpful for bipolar disorder. Well, now we know they're helpful in major depressive disorder. Specific second-generation antipsychotics that have FDA approvals for antidepressant augmentation for major depressive disorder include aripiprazole, brexpiprazole, olanzapine, and quetiapine. Okay, now the second area is truly novel. Within about a year ago, esketamine, also called Spravato, was approved for the treatment of resistant major depression in combination with an antidepressant. I'm going to show you a slide of where this drug acts. So what's exciting about this is, number one, it can work when standard treatments don't work. But number two, it's a novel mechanism of action. So hopefully we can learn more about the pathophysiology of depression. So I'm going to come back to esketamine in a second. The other area that's interesting for major depressive disorder is the area of neurostimulation. It's when we apply electric or magnetic currents to the brain. Electroconvulsive therapy, when we apply electric current to the brain, is still one of our best treatments. But, we have to put people asleep to get it. There's memory loss afterwards. And so other types of basically nervous system stimulation have been explored as treatments mostly for major depressive disorder. And this includes transcranial magnetic stimulation, or TMS, and then something we're doing research on at Linder Center, transcutaneous spinal direct current stimulation. So let me say a little bit about esketamine and neurostimulation. Here, this slide depicts an MDA receptor. So it's not a dopamine receptor, it's not a serotonin receptor, it's not a norepinephrine receptor. All classic antidepressants act at those receptors. This is an MDA receptor. This receptor is very important for learning and memory, and it's the site of action of esketamine. Here are some of the. Here is one of the initial studies that enabled the drug to get FDA approval for treatment-resistant depression, and you can see that, and it's given intranasally. So it's a real novel. It's not just a novel mechanism, but it's a novel mode of delivery. And you can see in this slide that these are people who had treatment-resistant depression. They got randomized to start a new antidepressant, as well as either ketamine or placebo. And the patients who got randomized to ketamine showed much more improvement, significantly more improvement. The most common side effects were nausea, dizziness, altered taste, and then you do have an issue with disassociation. You can have weird psychosensory symptoms with the compound. What's important about this drug is that it's not just been shown to treat depression acutely, but it's also been shown to treat depression over the long term. So if people respond to it acutely, there's a decent chance they will continue to respond to it, because we know depression is recurrent. So I'd like to just show, this is a major study showing that people with these are people with TRD, treatment-resistant depression, who responded to esketamine and then were randomized to either continue esketamine or switch to placebo. And what was clearly shown here is the people who stayed on esketamine had a much lower relapse rate, which is shown in the orange lines, compared to the people who got randomized to placebo. They had a higher relapse rate. So this is a very important novel treatment for major depressive disorder. I'm just going to say a little bit about a study that we're doing at Linder Center. because it stresses that the brain and the body communicate with one another, and we call these disorders mental disorders, but they're really probably they're body disorders or medical disorders. But this is a study of direct spinal stimulation. And you can see this shows where the two areas are. We apply current to the spinal cord, and that will then induce brain changes. And this is a treatment that's often used for chronic pain, and we are trying to see if this would be an effective treatment for major depression. Here's an example of a patient receiving that treatment. Okay, I'm going to switch gears a little bit here. What about medical treatments for post-traumatic stress disorder? We know that this is an incredibly common and debilitating condition. It's common in our military personnel, but it's also common in civilians. There are, in fact, 2 drugs approved for the treatment of PTSD, and they're both serotonin selective antidepressants, paroxetine and sertraline, and they definitely are helpful, but we clearly need more treatments. So what's new in the medical treatment of PTSD? Well, this is a slide depicting a press release from Lundbeck and Otsuka reporting a positive phase 2 study, which showed they took people with PTSD and they got randomized to sertraline and placebo, brexpiprazole and placebo, and remember, brexpiprazole is a second-generation antipsychotic. Or they got both drugs. They got brexpiprazole and sertraline. And what they found was that the combination was superior to placebo, whereas neither brexpiprazole alone nor sertraline alone demonstrated significant improvement. Okay, this is a very interesting finding. So it's again suggesting that this combination of a second-generation antipsychotic and an antidepressant can be helpful, well, not just for major depression, but maybe even post-traumatic stress disorder. Okay, that was a phase 2 study. So I just want to let you know that phase 3 studies are going on to try to replicate this, to see if an FDA approval can be acquired for the treatment of both these drugs in combination for PTSD. In the meantime, though, so that even though this specific combination isn't approved, it's still, we would think that it would work with pretty much, any second-generation antipsychotic in combination with any serotonergic antidepressant. So this is a nice option for people with PTSD that's not responding to antidepressant therapy. Okay, let me just get back to transcranial magnetic stimulation a little bit. Here's a slide or a schematic depicting what happens. You place a metal coil on the person's head and you deliver magnetic stimulation to different areas of the brain that we think are involved in different disorders. This treatment is approved for depression and has been recently approved for obsessive compulsive disorder and smoking cessation. And what's interesting is they will target the magnetic stimulation to different parts of the brain. Unfortunately, a recent study of this treatment in PTSD was not positive, but it's important to remember that TMS is now has approval for not just depression, but obsessive compulsive disorder and smoking cessation. Here are the data from the TMS study in obsessive compulsive disorder. So people with obsessive compulsive disorder got randomized to either receive real TMS versus sham or pretend TMS. And you can see that the people who got real TMS had a much greater reduction in their obsessive compulsive symptoms compared to people who got the sham or fake TMS. Okay, what about the treatment of eating disorders? This is actually one of my specific areas. Eating disorders are a large public health problem. They've been neglected. We still do not have an FDA-approved treatment for anorexia nervosa, which is the psychiatric illness, the mental disorder associated with the highest mortality rate of all mental disorders. People die by suicide and starvation. So we do have 2 FDA-approved treatments for eating disorders. This includes fluoxetine, which is a serotonergic antidepressant for bulimia nervosa, and then a new treatment, a novel area, is lisdexamfetamine for binge eating disorder. Lisdexamfetamine is a stimulant. It is approved for the treatment of attention deficit disorder. And a large program showed that it was highly efficacious in reducing binge eating in people with binge eating disorder. So what is binge eating disorder? These are people, okay, so both bulimia and binge eating disorder are characterized by binge eating episodes. Binge eating episodes are episodes of overeating where an individual eats an abnormally large amount of food for the situation, and there's a sense of loss of control over the eating. This is a very painful disorder. It's associated, not surprisingly, with obesity. And as I said, there's only one approved treatment for it. And that's lisdexamfetamine, which is a stimulant. There was a very nice program looking at another class of compounds called dopamine norepinephrine reuptake inhibitors. And that's dasotraline. There were 2 very positive studies of this particular dopamine norepinephrine reuptake inhibitor in people with BED, but for some reason, the company developing the drug has decided to withdraw it. So what our group has done, there's a very interesting link between narcolepsy and binge eating. So we noticed that a new drug has been approved for the treatment of narcolepsy. And this drug is also a dopamine norepinephrine reuptake inhibitor, just like dasotraline. It's highly efficacious in narcolepsy. You get weight loss. And so we are now starting a study of this compound in binge eating disorder. And then there's some other very interesting areas of research going on in binge eating disorder. As we learn more about the biology of eating behavior, we are coming up with more candidates, drug candidates for treating eating disorders. And the other really exciting thing is that when something works for binge eating disorder, when it reduces the binge eating in binge eating disorder, we have data that suggests it might also reduce the binge eating in Bulimia nervosa. Okay, so now I'm going to talk a little bit about the overlap of mental disorders and obesity. And this is one of my areas of research. So we know mental disorders are extremely common. 1 in 4 to 5 adults and 1 in 6 youth each year will experience a mental disorder. Mental disorders may be increasing. Well, we know obesity is clearly increasing and is now very, very common. So that now our recent data show that 40% of adults are obese in the United States, and 18.5% of children. So there are some who argue obesity is going to become the biggest killer on the planet in the near future, because obesity is associated with enhanced mortality. So what's important to realize is that many, if not most, mental disorders are associated with obesity. So which ones does that include? Well, the eating disorders defined by binge eating. I mean, that sort of makes sense. So binge eating disorder, where people binge eat but don't purge, people with BED have very high rates of obesity. People with bulimia also have high rates of obesity, although not as high as those with binge eating disorder. People with bipolar disorder have high rates of obesity. Certain forms of major depressive disorder appear to be associated with obesity. People with schizophrenia or other chronic psychotic disorders, again, have very high rates of obesity. And even anxiety disorders and attention deficit hyperactivity disorder are associated with obesity. So the interesting question is, what mental disorders are not associated with obesity? Well, that would include anorexia nervosa, which is associated with underweight. Here, I'm going to just show you a couple slides now that show this overlap of obesity and mental disorders. This is a 20-year study looking at body mass index, or weight, in a group of patients with bipolar disorder or schizophrenia after they had their first hospitalization for psychosis. And you can see that initially, they're at the very beginning of the study, the rates of obesity were not high. But after 20 years, nearly 2/3 of people with schizophrenia had obesity, and half of people with a bipolar disorder had obesity. So why? Why do we see this relationship? We have a bunch of hypotheses. We know people with mental illness often have poor dietary habits. They often have reduced physical activity. They just aren't as active as compared with people without mental disorders. We know a huge culprit is the weight gain effects of psychiatric medication. And that's just a huge issue. It may be that some mental disorders actually cause obesity. For example, binge eating disorder. People with binge eating often start out normal weight, but once they start to binge, then they gain weight. And I think the point that I like to stress to people is that the brain circuits involved in mental disorders and the brain circuits involved in eating behavior and weight regulation overlap. So here is a slide depicting that. So areas that we think are very important in the etiology of mental disorders are also very important in controlling food intake and body weight. So prefrontal cortex, the hypothalamus, midbrain. So there may be, so it's important to explore this relationship to see if we can find anything that will be helpful to teasing this apart and helping our patients. So, why treat obesity in people with a severe mental illness? So this is what our group does. We treat people who have mental illness and obesity. Well, as I mentioned before, obesity is common in people with severe mental illness. We think it adds, obesity enhances mortality. And we think that, we know people with severe mental illness have reduced lifespans. So we think obesity may be one factor that leads to the increased mortality and morbidity of individuals with severe mental illness. The other thing that we see quite often is people with mental disorders find obesity extremely distressing. And it's not uncommon to be working with an individual who feels their obesity is much more upsetting to them than their mental disorder. And so it's definitely associated with medication non-adherence. So what we've noticed also is that people with a mental disorder and obesity have two stigmatizing conditions. So we feel it's important that both conditions are dealt with. And finally, the other interesting line of evidence is that obesity is probably really bad for your brain. And it may be associated with poor outcome of people with mental disorders. So, for instance, we know obesity is associated with the development of dementia. So the question is if we can successfully treat somebody's obesity, will that help improve their mental illness? So just to remind people of the standard treatment of obesity, the treatments depend on your BMI. So so we start with lifestyle modification, we then move to pharmacotherapy, and then in severe cases, we will move to surgery. I think what I want to stress here is lifestyle modification is always important. It's always a component. And the other thing I'd like to stress is that there is no medication yet approved for the treatment of weight gain due to a psychiatric medication. We do have a few medications that appear to be helpful. This slide shows some of them. It's a little old because some of these medications are now off the market. So the two medications that we feel are most helpful for treating weight gain due to being on an antipsychotic are metformin and topiramate. So are these medications indicated for the treatment of obesity in people without a mental illness? No. Here is the list of drugs approved for the long-term medical treatment of people with obesity. What I like to stress here, there's orlistat. That is all of the other drugs besides, orlistat acts on the gut. It blocks the absorption of fat. All of the other ones, the bupropion, naltrexone combination, phentermine, topiramate combination, and liraglotide, all act on the central nervous system. Again, what is it about this link between mental illness and obesity that's so important? Now, having said that, it's important to understand that these compounds, these weight loss compounds, can have adverse psychiatric effects. Orlistat has been reported to cause slight increases in anxiety. The bupropion naltrexone combination is associated with anxiety, sleep disorders, and rarely mania and psychosis. And the phentermine topiramate combination causes insomnia, and it may enhance depression and anxiety, and again, in rare instances, can cause mania and psychosis. So that leaves us to liraglotide, or it's called, the brand name is Sexcenda. This is a really exciting compound because it causes weight loss with minimal adverse psychiatric effects. It affects the glucagon-like 1 peptide receptor. Those receptors are in the brain and in the gut, and it enhances satiety and reduces appetite. Here are just some preliminary, these are some of the initial data that led to the approval of liraglotide or Sexcenda in obesity. And you can see there's a very nice dose-response relationship, so that the greater the dose of liraglotide, the greater the weight loss. And I don't know whether you can see this, but the first line is placebo. The second line is orlistat. So you get much more weight loss with liraglotide than you do orlistat. So what's so exciting about this? Well, our group and others are starting to use this drug, these family of drugs, in the treatment of people with mental disorders who are overweight or obese. And here's a published study looking at this compound in people with schizophrenia who were overweight or obese and had pre-diabetes. So they were beginning to develop diabetes. And what's exciting about this study is not just that patients who got randomized to the active drug, patients who got randomized to liraglotide, compared to those who got placebo, showed greater weight loss, greater improvement in blood pressure, greater improvement in their diabetes parameters, greater improvement in lipid parameters, as well as, and this to me is what's intriguing, there was a trend. It wasn't statistically significant, but it was a trend. But the people who got randomized to liraglotide had a lower hospitalization rate for their schizophrenia. So the question, if you look at the bottom line, it says hospitalization for worsening symptoms. So only 6% of patients who got liraglotide had to be rehospitalized for worsening of their schizophrenia symptoms, compared to 18% of those of placebo. Now, this is a small study, so maybe this finding would have been significant with a larger study, but it suggests that again, if somebody has obesity, we need to address it for many, many reasons, including the fact that it's bad for the brain, and we might have beneficial effects on the mental disorder if we can successfully address obesity. Okay, as I wrap up now, I just want to say that our group is looking at this compound not in people with schizophrenia and obesity, but in people with bipolar disorder and obesity. We've got a study going on. We're about 2/3 of the way through, and we know some people are losing weight and some people aren't, but we're very excited about this study. So, in conclusion, when treating mental disorders with medical treatments, number one, you have to establish an individual's complete psychiatric profile. Okay, if they have schizophrenia, do they have an anxiety disorder? Are they using drugs? You also need to establish their complete medical profile. So we weigh all our patients. We want to know if they've got obesity or not. We check their thyroid tests. And then once you have this information, then you can decide on an appropriate medical treatment. Thank you so much for your attention. If there's any way we can take questions or comments, that would be wonderful. But again, thank you so much for your attention. And goodbye.